while we can. Okay. Um, so for week 3, we're focusing a lot on preventive care and women's care and then adolescent care as well. Um, objective wise, um, so lots of key factors in encouraging adolescents to seek healthcare and be able to verbalize recommended preventive healthcare measures for the adolescents and various methods of contraception and be able to assess the best contraception method for a patient and be able to recognize various STIs and recommend treatments for them. All right. So tell me what you think for this. Good. We're not old enough for that, right? So with cervical cancer screening, under 21, no screening. And that used to not be a thing. There's some people that still aren't aware, a lot of older generations that until their daughters have gone through the process of knowing, okay, that's not the guidelines, they are still bringing in their daughters thinking that they need to be screened and they're like 18, or because it used to be at once they turned 18 or once they were sexually active. So if they were 14, then we would do pap smears. Now it's not until you're 21, regardless of if you're sexually active or not. 21 to 29, then you would do cytology alone every 3 years. Once you hit 30, then you would do HPV and cytology co-testing, and you get to space out to every 5 years if both of those are negative. Then 65 and over, you do not have to screen anymore as long as they've had adequate negative prior screening. And that's a little bit of a gray area of what you consider adequate. But if it seems like they've been regularly screened and their last several have been negative, then you can stop at 65 reasonably. After hysterectomy, please do not try to do a pap smear if you ask them. The most common thing is that people just don't even ask and they just go and do it. So then I'm like, what? I've seen charts. I'm like, what did you swab? I'm like, I don't know. Okay. Did you see a cervix? I thought so. Like, okay, there was not one. Um, so that's one a little bit of a clue that you can do and not embarrass yourself is at least ask if they have a uterus. But also another caveat to that is that there was a period of time, and I don't know which years it was exactly, but where they used to do the hysterectomies and leave the cervix because the thought was that it helped with sexual pleasure. They found out that wasn't true, and those poor women had hysterectomies and still have a cervix, so they still have to do the pap smears. So not really fair, but you do have to ask, did they also take your cervix? And most of them say, oh yeah, they took everything. But if you don't know, you can always do an exam and see if you see a cervix. Or find the op report. That's also helpful. The other thing is if they had a hysterectomy, but then they had a history of CIN2 or higher in the past 20 years, or any cervical cancer ever, then you would continue to do pap smears. I was going to say something else and now I don't remember. Um, oh, yes. So that's why it's important to ask also why they had their hysterectomy. I can't tell you how many times I've asked the residents what was the reason for the hysterectomy, and they have no idea. Most of the time, it's going to be because of bleeding, almost all the time. But sometimes will be that off chance that it was because of cancer, and so you do need to know that so you know whether or not you do need to continue screening. Okay. All right. Move this box up. So for osteoporosis screening, this is why for that first question, with a 52-year-old, that was the correct answer because she is not yet 65. And we are not aware of any other reasons that she would have to have screening sooner. Okay. So 65 and older, every woman should be tested. If they are postmenopausal women younger than 65 at increased risk of osteoporosis, then they also do recommend screening because they are at increased risk of osteoporosis. There are other reasons that women could be at increased risk of osteoporosis, whether or not they're postmenopausal. Do you guys know any ideas for that? What would be other reasons I need to do DEXA scans earlier? Yeah. So like if they have lupus and they're on chronic steroids, then they would need to be doing DEXA scans earlier. Or if they had a kidney transplant and they're on chronic steroids, I have a male that I get DEXA scans regularly on because he's had a kidney transplant and he's on steroids. So he's at higher risk for osteoporosis. Normally we don't do them in males, but someone like that, we would. Okay. All right. So chronic steroids, low BMI. So if they're like anorexic, have eating disorder, something like that, or if there is a parent or sibling with osteoporosis, you would also consider screening sooner than 65. Okay. So menopause, average age is about 51 years, but women can be perimenopausal for 10 years, which sounds absolutely scary if you tell that to a woman. Oh, and while I'm thinking of it, just because I know I didn't do your guys' orientation and Dr. Adams did, and she may or may not have mentioned this, but I have spent a lot of time redoing the week 3 and week 4 PowerPoints. I know, and Dr. Chow updated his as well with like the vaccines things, but please, 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 after today, do not ignore the PowerPoints. People that have failed this course in the past, I would ask them how they studied and then specifically ask them, do you go back and look at the PowerPoints? And they say no. I'm like, okay, well, that's the problem. Not that you can only do this and pass, but a lot of content is going to be within these PowerPoints. So do not ignore these. Okay. A lot of this is very intentional information put into here. So for example, starting menopause at 41 with hot flashes, changes in cycles, mood swings, they can have all or none of those symptoms. Okay. So, alone, some of those things can be from other things. So a lot of it's history, age, asking about their cycles, asking about when their mother went into menopause can all be clues with that. Signs of menopause. So these are normal ranges of these hormones. There's a very wide range, as you can see, for FSH and for estrogen. So when somebody asks you to say, can you check if I'm in menopause, drawing these levels really don't tell you much until they're out of range. And it can take 10 years for that to happen. A lot of, if they're quote in menopause, is going to be based on the history. Are you having hot flashes? Are you having mood swings? Are you having increased frequency or decreased frequency of your menses? Then yes, you're likely in menopause. But these are the normal ranges. I've included normal ranges on a lot of these slides for you to know, because on your questions, some of the time, if you don't know what the normal is, it's going to be really hard to answer the question. Okay. So make sure you know all these normal range values of ones that I've included in here. Okay, so menopause, when someone is in menopause or premature menopause, especially, that increases the risk of osteoporosis. Okay, so if they are in their 30s and these hormones are out of range, then they're in premature menopause. All right, osteoporosis, interpretation and monitoring. So these are the values for the T-scores to interpret DEXA scans. So a T-score of -1 or above is normal bone density. Okay, so that's what you're looking for. Every 2 years, if they are high, so screening wise, they need to go every 2 years if they're high risk, every 3 to 5 years if they're moderate risk, and every 10 to 15 if they come out low risk. All right, thyroid screening. It's a grade I recommendation for screening, okay? But screening versus diagnosis is very different, and that is a recurring theme for all of these things. Anything that's preventive care is preventive care if it's for screening purposes. But if you have symptoms of things and it's no longer screening, you're trying to diagnose at that point. So that's what I'm meaning by that second line. But if there are symptoms, you test. At that point, it's diagnostic versus screening. If the TSH is elevated, levothyroxine is the typical treatment for that. You're probably familiar with that, levo. And you will see the TSH level respond by decreasing. For checking the levels, a patient will say, okay, when do I need to come back and see you? You don't want to recheck their TSH level until 8 weeks later, in order for that medication to reach its steady state. And after that 8 weeks, they come back, get a TSH redrawn, and then you say, okay, we need to go up again on your levo, or oh shoot, we overshot it. We need to go somewhere in between what you were on before and this one. Okay. So you do want to kind of have that concept. Okay. You'll also want to know this algorithm and the normal TSH value. So let's say that you have a thyroid nodule, may have been found one way or another. Very commonly can be an incidental finding. You also look at the history and physical exam. If their TSH, you do the TSH and the ultrasound of the neck. If the TSH is subnormal, then you'll do a thyroid scintigraphy, or also known as a radionuclide thyroid scan. Okay. If the TSH is normal or elevated, then you'll look to see if they've met criteria for FNA, fine needle aspiration. If it's a nodule that is greater than or equal to 1 centimeter, then it's suspicious, and large, greater than or equal to 1.5 to 2 centimeters, then that is concerning. You would do an FNA, and you'll get that cytology from that. If it's smaller than that, you'll just keep monitoring. Okay, but TSH is subnormal. You do the thyroid scan, and you see if it's a hot nodule or not, and they'll proceed from there, surgery, etc. Okay. I can't, hold on. Where is my cursor? I don't know what I'm doing, guys. Sorry. Hold on. Okay. Anybody? No. Nope. Okay, we'll just read the first line and then I'll go back to a 32-year-old primogravid woman at 15 weeks gestation comes to the physician because she noticed swelling of her neck 2 weeks ago. Okay. And then you can read the rest. What's your answer? Go backwards if you need. Yeah. Okay. And a lot of these questions, I pulled from AMBOSS, so you might see them again when you're studying. They're good questions and will help you to learn the material that you need to know. And if it is, I put it in the comments under there so you can see if it's from AMBOSS or not. I don't remember which ones were which, but okay. Graves' disease. It's an autoimmune disease in which the TSH receptor autoantibodies stimulate the thyroid gland, so you have an increased thyroid hormone production. This is the most common cause of hyperthyroidism, so they'll have a low TSH with this. So they'll complain of like swelling in their neck, or they have this big ball, or their neck is looking big, and then they may not notice unless somebody points it out, but you'll see, I mean, people will walk in or walking around and you'll see this on people. And then the pretibial myxedema. They may have one or all or none of these yet, depending on how advanced their disease is. But here, you'll see that there is bilateral enlargement of the extraocular muscles where those white arrows are pointing to, except they're right lateral. Look at this. Labs will have a low TSH and an elevated TSH receptor antibody. And treatment-wise, you'll do beta blockers, anti-thyroid drugs, radioactive iodine, ablation, or thyroid surgery, like on that previous slide with the hot nodule. Okay. Colon cancer screening. Okay. So it's still a class A recommendation for 50 and above, but the 45 is what we use clinically. It's class B, so not as great of class A, but everybody is very well on the same page with that. Insurance is on the same page, so we don't really get pushback with that. We don't have concerns with it. So 45 is the new recommendation. And what I've told previous months rotations is I don't remember there being one where it's like there's a 47-year-old is he due for a colonoscopy, right? Because then you're like, oh, I don't know, is it based on the new guidelines or the old guidelines? There is not one like that I can remember, but if there are any questions where you're wondering, should I know this is new and that this test was probably made before these recommendations came out, always go with what the most recent are. And if there is a change and you get it right because of the most recent recommendations, we will give you credit for that answer. Okay, so I don't want you having to think, oh, is this an older question or should I go with the older recommendations? Just always go with what the most recent guidelines are. You might see some, depending on how updated like you rolled the AMBOSS questions, et cetera, are, you might see different ages that I'm not for sure. I haven't pulled questions for that from there, but it is 45 is what I want you guys to use. Which is pretty new. There's a lot of people that are not aware of that. So when you're having those conversations with patients, a lot of them are going to be surprised because they'll think that they'll have a couple more years, like, oh, they're actually past due. Okay. So there's various ways of doing colon cancer screening. Obviously, you guys all know about the colonoscopy that you would do every 10 years if it's completely clean and they have no risk factors, they don't find anything, okay? Other methods are with an FOBT test that you do have to do every year. And actually, so I had one patient that refused to do colonoscopies, and this was before Cologuard, and we'll talk about that in a second too, but she wanted to do the FOBT every year, and she was always behind because she wouldn't even see me every year. But to actually qualify for that, it's every year, and you have to send in 3 separate stool samples. So it's pretty burdensome to accomplish that, and they don't really do it. Thankfully, they do have the SDNA Fit, which is the Cologuard that you may or may not have seen commercials about. I know you guys don't do a lot of TV right now, but it's approved for doing every 3 years. You can do up to every year, but it'll say due in 3 years when you get the test back. It's similar, like they still have to collect the stool sample and they send it off, but it's just one stool sample. They send it to a company. The company sends the kit to their house. They collect it and they send it back to the company. It's all free of charge for them. And they analyze it and then send results to their PCP. And it'll tell you if it's negative or positive. If it's negative, they're good for 3 years. If it's positive, they have to do a colonoscopy anyway. But I do go over those options with them. Some of them want to do the colonoscopy because they'll say, well, I know that I'll just never do the Cologuard if they send it to me, and I don't want to put the responsibility on me. I would rather go ahead and make the appointment and force myself to go in. Also, you buy yourself more time. Also, if there's something there, then they can take care of it right then and there. They can clip it, get rid of it, whatever they need to do. Yeah. Any other questions about that? Okay. So special considerations. Remember that if there is a positive family history, you do need to screen 10 years earlier than the age of the family member at the time of diagnosis. And even if it's a clean colonoscopy, they still have to go every 5 years instead of every 10. So you want to make sure that that information is in your referral whenever, or like in your diagnosis codes that you tie to their colonoscopy, so that the person reading their colonoscopy, going over it, knows, oh, there's a family history. I need to not tell you to wait 10 years. I need to tell you to come back in 5. High-risk populations should generally be screened earlier. So if they have ulcerative colitis or Crohn's or familial polyposis, anything like that, then they, in general, will be screened earlier. So ulcerative colitis and Crohn's, specifically, they would screen 8 years after symptom onset. So you just kind of have to, this is a little bit hard of a recommendation, because sometimes, I mean, they'll be having symptoms for who knows how long, and then finally, maybe years later, get a diagnosis of ulcerative colitis or Crohn's. Maybe after they eventually, sometimes get a CT, and then they say, okay, well, we should do a colonoscopy. They get that colonoscopy, and so then, they have the colonoscopy done at that point. But if they haven't, but they have this diagnosis, then they have to think back, okay, I think my symptoms actually started maybe 3 years ago, then they would be due 8 years from that time. It's a weird recommendation, but that's what it says. Abdominal pain. Okay, so a very large differential because of referred pain. Right. So when people go to the ER, and it's kind of like with chest pain, where chest pain can kind of come from almost anywhere. It could be their bladder with a UTI, or it could be from their lungs, or it can be from their esophagus, like they're having acid reflux. Abdominal pain as well, a very large differential. In regards to GI, because I mean, if we're talking broad, especially females, there's a whole lot of things, right? But specifically with GI, constipation, H. pylori, if you haven't heard of that, we do roll that in or out with the H. pylori breath test. We do that in clinic. You can do serology, but it doesn't tell you if it's a new infection. The H. pylori breath test will tell you if they have a current infection. Also, you want to be thinking about acid reflux or dyspepsia, and think about offering an H2 blocker or omeprazole. Okay. All right. Here's another question for you guys. What do you guys think? It is A. Good job. Yeah, so a lot of the time, more information is going to be the right answer, right? You don't have enough information to go and do a surgery on her, or even to do genetic testing. The next slide kind of talks about it as well, but you have to send somebody for genetic counseling before you ever even do genetic testing, and there's quite a bit. But this is an AMBOSS question. Let's see. So yeah, so you want to, at the bottom sentence, women with a positive result on the risk assessment tool should receive genetic counseling, and if indicated after counseling, genetic testing. So we can jump the gun with a lot of those other options. All right, so here I have bolded here, because for the most part, USPSTF is what we go off of. But this says biennial screening mammography for women aged 40 to 74. Testing purposes, I want you to do yearly. That's actually what we practice anyway in clinic. I do yearly mammograms for my women, but that is not what the USPSTF guidelines say. So if you see a question and you're wondering if she's due or not, you need to do yearly.
Did you say test purposes as well?
Yeah. So for high risk women, breast cancer screening, so women with a personal or family history of breast, ovarian, tubal, or peritoneal cancer or an ancestry associated with BRCA1 or 2 gene mutation would all be considered higher risk. Okay. So you do the familial risk assessment tool. If they have that, this is like what I just said. They should receive genetic counseling, and if indicated, after counseling, genetic testing. The BRCA testing is recommended for evaluating breast cancer in patients with a family history of any of these things, or in some patients after breast cancer is diagnosed and a first-degree relative is affected. Okay, so that's why a lot of the time they need to do that genetic counseling to even see if they should have the BRCA testing. Okay. UTIs and STDs. Either one can be symptomatic or asymptomatic. So for a lot of these things, if they come in wanting testing, they have some type of reason. I've seen some people tell people, no, they're not going to keep testing them. And I don't know. I mean, we have such a widespread disease of STDs. I don't know why you would deny somebody, but for book purposes, if there's any reason to, you just do it, you test them. Special considerations. Whenever you are giving somebody medicine for any reason, I should not have to say this, you'd be surprised, but you do need to take into consideration drug allergies. So like before prescribing an antibiotic, you need to also know what the reaction was to an allergy that they had, right? So if it was a penicillin allergy, remember that penicillins cross-react with cephalosporins. So by the book, if it's only a minor reaction that they had to a penicillin, you can give a cephalosporin. But if they had anaphylaxis from a penicillin, you do not want to risk cross-reactivity. Do not try a cephalosporin. Okay. Medication interactions you also need to be aware of. We always want to be aware of, but especially with warfarin, that's one of those ones that interacts with everything. But remember that it does have a bad reaction with Bactrim. So you do not give somebody Bactrim if they are on warfarin. I'm saying all of these things for a reason. Okay. STD screening, like I said, I mean, if there's a reason, you screen them. If they're, so our pregnant people, that's one that even if they have no symptoms, no reason, no suspicion, anything like that, we rescreen them at their first OB appointment, so at their OB intake visit. And then that last one, the USPSTF recommends clinicians screen HIV in adolescents and adults age 15 to 65. So they should be screened at least once during that time, but also any other time whenever they're at increased risk. They've had multiple partners, unprotected intercourse, possible exposure, etc. All right, so we'll kind of go through some of these. Gonorrhea is that gram-negative diplococci, can affect many different places, can be asymptomatic in males or females. I know that it says nucleic acid amplification there, but how am I actually testing for gonorrhea? If you are with me in clinic and I say, let's test for gonorrhea, what am I actually asking you to do with the patient?
Like different tests or like a physical event?
Yeah, so like what kind of test would I want you to do for them?
Cervical motion.
Yeah, you don't get it as much with gonorrhea as chlamydia, but that is something you can look for. If they're just like sensitive or tender in general, yeah. But what am I culturing?
I guess like how you get the
Uh-huh.
culture,
Uh-huh.
cervical swab or something.
Okay, you can. Is it in the cervix, in the vagina? Where am I putting the swab? So it's endocervical. So you do have to visualize the cervix. And there's different swabs for different things, but for gonorrhea, you go endocervical. Or you can just ask them to pee in a cup, and then you can test the urine. That changed. That was not a thing until I wasn't attending. We used to have to swab everybody for that, but you can get it off of urine, and it is pretty sensitive and specific that way as well. For chlamydia, so the obligate intracellular gram-negative bacteria, also many sites can be asymptomatic. And that one, you're going to be looking for a thick yellow vaginal discharge. You may or may not see that in real life. And then treatment-wise, doxy for 7 days or azithromycin 1 gram once. How am I testing for chlamydia? So same question as the last one, but how am I actually doing it?
So outside the cervix is done.
Good guess. Not yet. But so this one, it's actually the same exact swab. Your gonorrhea and chlamydia are the same exact swab. It's actually the same order even. You don't even have to click two different things. It's just this GCCT typically whenever you order it. So again, also you can do it on the urine. And it's still just the one order for both of those things. One thing that has come up, again, I don't think it's gonna, like, testing wise, I don't think it matters for you guys, but people have asked because they've seen it on contradictory things like on Amboss versus other sources, where for a long time we were taught that if they are positive for chlamydia and negative for gonorrhea, you treat the chlamydia, you don't have to treat the gonorrhea, right? But if it's the other way around, they're positive for gonorrhea and negative for chlamydia, you still treat for chlamydia because it's an intracellular gram negative. Some people have seen that that if chlamydia is negative, you don't treat for it anymore. I looked up in an article, a JAMA article, and it similarly said the same type of wording where it says that if chlamydia, you only treat whatever is positive, basically. But it didn't have an explanation for why that changed. And I don't know if the testing is just better now or exactly. I keep asking each group, but you guys are all in the same class, preclinical, so I don't know that you've heard anything differently. But I think the push is going to be as you progress that you are only going to be treating whatever is positive. I just don't know why, but you still might see differing things. And like in the ER, they're still preemptively treating for it. So it's definitely hasn't widespread yet, but just a conversation for you guys to be aware of. Chlamydia, you can see here or here. Some, this one is that would be a very, very angry cervix with that classical discharge. But it's not going to always look like that in real life. It can look very healthy and then be positive. All right, for Trichomonas, it's the flagellated protozoa. Again, can be asymptomatic. And this one you're gonna be looking for these keywords: green frothy discharge and strawberry cervix. So I tried to find some pictures demonstrating that if you ever see those things. That's the best pictures I could find of demonstrating those. But you're gonna do direct microscopy of a wet prep. So here, this one is the one where it's outside the cervix. So it's in the vagina, in the vaginal canal, where there'll be discharge just kind of sitting there, kind of in a pool, that you can collect. And that one, we don't have a urine option. I've seen some people, I mean, there is a urine option. I just don't think it's very good because it hasn't been recommended as a method of testing that I've seen. So technically, you should still be doing that wet prep. And then you would give them metronidazole as either of those dosings options. HPV, again, you'll want to be familiar with the slide, can cause anal or genital warts. They can be benign, and most often cause HPV type 6 and 11. It can come in various shapes, sizes, colors, can be symptomatic or asymptomatic, can be inflamed, or not cause any problems. They can cause any kinds of itching or burning or bleeding. And then lots of treatment options. Liquid nitrogen therapy is one that we use commonly, but Imiquimod and Podophyllin are also options as well. All right, so HIV, again, if you have any reason to test, you're going to do it. If so, just because it's a sexually active male, there is no evidence to just screen them as it's class I. Pregnant people, class A, that you're going to screen them every single time they're pregnant, even if it's only been 9 months since their last delivery. Adolescents and adults, again, you're gonna screen them at least once during that time period, and then any other time that they're in increased risk. So these are some things to remember, what the normal CD4 count is, and then any patients with CD4 of less than 100 should be given Bactrim prophylaxis. And anytime somebody has a low-grade fever, you're gonna need to rule out HIV amongst other things. A chronic low-grade fever, not if they just have it for 2 days and then they're fine afterward, but recurring or chronic. Okay. Bacterial vaginosis is not an STD. It's a very common question, because you don't want to get people in trouble when you tell them they have bacterial vaginosis. Intercourse does put people at higher risk of having bacterial vaginosis, but it is not an STD. It can cause symptoms that mimic an STD. They might have vaginal odor, increased vaginal discharge, and usually we find it while we're testing for other STDs. But you can test for BV alone if needed. You know, they just had it and you try to treat it, but they're not sure if it's gone, or they might still, or it did get treated and left, and they think it might be back. But it is caused by a change in pH and overwhelming bacterial flora of the wrong type. They, did like douching or something, got rid of the healthy bacterial, so now they have this other bacteria that are kind of overwhelming things. Or they had intercourse, semen changes the pH. Taking a bath changes the pH. Using soap inside of the vagina, which is not recommended, also changes the pH. So a lot of education with them, and explaining to them things to have, like with healthy hygiene, not wearing like tight leggings all the time, and using cotton underwear versus other like silk or whatever underwear also helps with the bacterial vaginosis. Probiotics is something else that is a little controversial as well, but seems to help anecdotally, with a lot of patients in bacterial vaginosis, that they have resistance with it. But a lot of times it'll be a gray-white discharge, otherwise normal, but it does have a fishy odor. You treat that with metronidazole, may recur and require multiple treatments. We talked about that. Okay. All right. Answer this one for me. It is B. Good. So really not old enough for these other things, and she's up to date on her vaccines. We don't really have a reason to get a CBC. So essentially STD testing is what she would be due for. All right, here is a slide of normal values that you do need to know. Some of them are repeats. I think, yeah, I think this is the only one that hasn't, well, that one is. Anyway, you need to know all these, or it'll make it a little bit difficult to answer some questions. I've seen some people answer things that I think they got wrong just because they didn't know the normal values. So make sure you know those. You guys already had your immunization talk, but these are just some things to take into consideration. Of course, ensure that all our vaccines are up to date whenever they're coming in. Usually the nurses will help with that. Go with whatever the CDC says is the most up-to-date vaccine schedule. So if you see any contradictory things when you're doing practice questions, go back and look at the CDC, and because something changed in like I think October. There was a change with pneumonia vaccines. Again, we will give you credit for whatever is the most up-to-date guideline. So you don't have to be thinking and questioning yourself with that. You really, really, really need to know the immunization schedules inside and out. The schedules, the special populations, special considerations, what populations need vaccines early, contraindications, and like immunocompromised individuals. And remember, the immunocompromised includes people with IBD, regardless of if they're taking steroids or not. They are considered immunocompromised, so they would fall under that schedule of vaccines. A history of a severe allergic reaction, aka anaphylaxis, to a previous dose of the vaccine or any of its components is a contraindication for any particular vaccine. So if they had the flu vaccine and they had anaphylaxis, you do not give them the flu vaccine again. Do not. But if they say, oh, I have an egg protein allergy, but they don't have a severe reaction to a vaccine, that's not a contraindication for an egg protein containing vaccine. You can just monitor them if needed, but that is not a contraindication. So for example, flu vaccine, pneumonia. So they say, I have a egg protein allergy. That's okay. They can still get the flu vaccine. They can still get the pneumonia vaccine, unless they had anaphylaxis before. Of note, none of the routine immunizations scheduled at the 4 months. So none of those have egg protein allergy or egg protein components. So those would all be safe, even if a parent said some concern about egg protein. Okay. All right. I'm not going to read all of these, but there are 2 slides of these that you do need to memorize. So there's multiple versions of the test for the shelf that we have. So it's but between them all, there are lots of questions, and it's more heavily emphasized than I would have imagined. But you do need to know these. Okay, so both of those slides, make sure you know them. Okay. All right. Now moving into the adolescents. Okay. All right, let's see. All right, what method of motivational interviewing did the last question demonstrate? Their goals. Okay. So hold on. Let me look at exactly what I open-ended questions. But good. Yeah. So with there are going to be questions about the whole point of this is there's going to be questions about motivational interviewing as well. So make sure that you are just thinking, have that mindset of how to appropriately interview somebody asking them questions. Okay. Adolescents. So with adolescents, they are their own breed. That's why they peds there's a whole fellowship for adolescent medicine. You will want to not as a medical student, please don't. I don't want you to get in trouble with your preceptor. But when you hit residency, if you are in a position to do so and you're in primary care, essentially, you'll want to talk with them alone. I do the majority of my interview and my exam with the parent there, so that I'm developing rapport, the with the kid and the parent both, so they don't feel like a stranger is just about to talk to them by themselves. Like you got to read the room, and get into whatever questions you need. And then I ask permission for me to speak with them alone. And I tell them, I want them to get practice of talking to me by themselves, because at some point they're gonna need to do that, and I want them to be comfortable with that. And I'll ask them if it's okay. And they're not idiots. They know what I'm going to be talking about. And most of the time they're like, oh, please, yes. So they leave and we talk, and we kind of, again, ease into the conversation. And again, you have to kind of read the room because, I mean, I talk about, do any of your friends have, I always ask about friends first. Do any of your friends smoke? Do any of your friends drink? And sometimes that doesn't work because I've had some where their friends didn't, but they did because they had an older sibling that brought them into it. But they will usually disclose that. But a lot of time, if they're doing something, it's with friends. And then ask, do any of your friends have boyfriends or girlfriends? And then ask them, and if they're like, ew, no, then I'm like, okay, we're not there yet. But I try to purposely start early and give them the opportunity. And so then they know, oh, my doctor's going to ask me about this. So if I have questions, then I can ask them. And I set that routine and that habit so that if there is a point when they are feeling not safe at home or something's going on, or they're feeling suicidal, there's things that they don't want to talk about with their parents, that they know, okay, there's going to be a time when Dr. Jones is going to talk with me by myself, and so I can talk with her. So I try very hard to keep that routine with them. But you do have to ask the hard questions, and sometimes you get answers that you do not want to hear. And you have to deal with it, but that's my job, and that's how it is. I have had 2 well child checks where we found out they were pregnant at the same time. In my office, we did like, so are you sexually active? Yes. When was your last period? 2 months ago. Like, okay, well, yeah. So, but the other hard thing you have to think about is being aware of their privacy. Okay. If they're an adolescent, more than likely they are not on their own insurance, right? So anything that I order is going to eventually show up on paperwork somewhere, or billing electronic somewhere. It's going to show up somewhere. So I have to be really careful and remember that adolescent is my patient, right? And so you kind of have to talk through scenarios of how you want to approach things. And like with those, for example, we talked about it and got the pregnancy test and we got it back. They were not expecting it, of course, but and then we said, okay, so do you want me to have your parent come back in here and we can talk about it together? Or do you want to just kind of take some time and tell them by yourself? And both of them opted to go ahead and tell them themselves. But I asked, okay, what do you think is going to happen if you tell your parents? Because obviously I don't want to send them into a situation where something very bad can happen, right? A lot of them are, well, they're going to be really upset, but it'll be okay. Like, and so upset in what way? Are they going to hurt you, or are they just going to take your phone away or take your car? We kind of talk about those things and make sure that I'm not sending them back into a place where they may be harmed. Okay. All right. So with physicals, that's one of the more common things that you'll do at that age. Because I mean, if you think most teenagers are pretty healthy, right? They're not coming to their well child checks like they did as babies. And they'll go 2 or 3 years in between unless they have to get a physical. If they have to get a physical for school, they will come and see you. So with those, make sure that you ask about concussions, any previous injuries, and then cardiac and lung exams are quite key, because obviously I mean, that's what we always hear about. Um, so just pay special attention to that. I think I have another slide. Yeah. So with cardiac exams, you'll if you hear a murmur, you're gonna have to try to determine if it's a functional versus a pathologic murmur. If it's soft, it's probably not a big deal. If it's something that's pathologic, it's going to be loud. Functional is going to be position dependent. And so it'll vary in intensity or even disappear in a systolic murmur. Pathologic is not going, you're not going to, like, it's going to be loud and you're going to pretty much always hear it no matter what position you put them in. And it could be systolic or diastolic. Okay, so some of the questions that get missed are behavioral questions with teens, geriatrics, whatever. Just kind of remember that sometimes teenagers are just weird and try to think about how you were as a teenager. And I'm just going to leave it at that. Okay. All right. So Tanner stages, you do need to memorize this as well. I think I have a practice question here. No, I'll flip back in a second. Anybody? Yeah. So just be sure that you can answer a question like that. All right, contraception. So this is the last section. So types, there's going to be combined or progesterone only. Okay. Combined will be the estrogen, progesterone, or progesterone only is the other column. So with combined, they have the OCP options, NuvaRing, and Xulane. Progesterone only, you have the mini pills, the depot injection, Nexplanon, or IUD. The OCPs, obviously, they have to remember to take every single day at the same time within an hour window, essentially, or their chances of getting pregnant drastically increase. With these three on the side with the combined, you can take them where you can skip the placebo essentially. So if it's with the OCPs, typically they'll come in a pack of 4. They have the 3 weeks where they take them, and then the last week is a placebo pills where they'll take them just to keep track. But that's when they'll have their period because of the progesterone withdrawal. If they don't want periods, they can skip that last week, the placebos. It's still, I mean, people still think that they have to have periods. And so there's a lot of education with that where, I mean, people that have IUDs don't have periods for 5 years. So it is not a necessary thing. If they're not having periods and it's not medically induced, that is a problem. But if you're taking things to suppress your period, that's fine. So you can do that with OCPs. With the NuvaRing is a round, clear, kind of kind of a thick rubber band type material that is inserted into the vaginal canal. I usually will ask if they've used a tampon. People that use the NuvaRing are typically of like the younger ages. And so they may or may not have used tampons before. If they've used a tampon, then it might be a little bit easier for them because it goes in the same place. And similarly, I tell them that with the NuvaRing, so it's like the rubber band, like a rubber band, and then you squeeze it, so it's like a figure eight, and then you insert it into the vaginal canal, and then it pops open and it sits up there. That if they can feel it, they like get up and walk around and they can feel it, then it's not up high enough, just like a tampon. And so that's why I ask them that, because then they'll know where a tampon they should not be able to feel when they're walking around unless it's not up high enough. The NuvaRing is good for 3 weeks, and then they would have an off week. But similarly, they can just replace it every 3 weeks and not have a period. And with the NuvaRing, they can have intercourse, swim, everything. Oh, it's fine. If it accidentally comes out during any of those events, they would just wash it off and put it back in. The Xulane is a patch, kind of like a little Band-Aid. So you know the little circle Band-Aids. This is like a little square or rectangle Band-Aid that you can put essentially anywhere in your body except for like your chest and your head or something like that. I don't remember. Places you wouldn't put them anyway. But so you can put it like under your bikini line or whatever they want to do. So it also works well for young people. And you change it every 7 days. And with that one, similarly, you would be on for 3 weeks, or you can have the 4th week off, or just continually wear the Xulane patches. The biggest complaint with that is if somebody has really sensitive skin, then skin irritation is a big complaint with that. For a lot of people, it might start to get kind of itchy around day 5, and they could just kind of grit through it, and then day 7, take it off, and then put a new one on. You just want to make sure that they don't ever put it back in the same, just they need to rotate essentially. For the progesterone only, there's the mini pills that are most commonly used right after delivery until like while a mom is breastfeeding until they are about 6 weeks out, where they can have something else. They can have any of these other things technically, but there's some data where like breast milk production might decrease if they're using something else. So some women will just want to do the mini pills for 6 weeks. But we have plenty of women that take the Nexplanon in the hospital before they discharge, the depot before they discharge. We put in IUDs right after delivery. So you can use any of these other things, but some people are cautious with that. The depot injection is a shot that you give every 3 months. That one, there is some data that's one that you'd have to get a DEXA scan early. So they could be in their 20s and maybe they've been on depot for 10 years. And that some data has shown that some increased risk of osteoporosis with long-term use of depot injections. That one is also unique in that it gets dispersed into the fat within your body as well. So it takes longer to fully get out of your system. So it can take up to a year for depot to clear from your body. So a lot of people will ask, how quick can I get pregnant after using something? With everything else, when you take it out, they may not even have another period before they ovulate. And so they can get pregnant. But with the depot, it can take up to a year for them to regularly ovulate. The Nexplanon is a device that lasts for 3 years. It's about the size of a match that goes into the biceps groove in either arm. 3 years, and then they come back, they can get it taken out if they want to switch to something else, or we can use that same spot where I remove it to put in a new one. And then IUDs, There are lots of different kinds. The Mirena is probably the one you've heard about the most. But there's the Mirena, the Kyleena, the Skyla, and the copper IUD is the non-hormonal one that some people will ask for. If somebody comes in and says, I want the copper IUD because I don't want to have periods anymore, what would your response? What should your response be to them?
They make periods heavier, don't they?
Yes. So yeah, so some people are like, oh, I don't want hormones because I don't want my periods getting crazy. I'm like, well, actually, the copper IUD very commonly, because that's how it works. It works by irritating and inflaming the uterus so that they don't ovulate appropriately or it doesn't implant appropriately. So if that is their reasoning, then I would make sure that they are, once I tell people like, I didn't know that, like they just Google and think that if they don't have a hormone, then their periods will be good. But with the Skyla, it's 3 years. The Kyleena, it's 5 years. And then the Mirena, how long is the Mirena good for?
8.
It is 8 for some people. Trick question.
It's different if you're using it for contraception versus like period control, right?
Yes, very good. Yeah, so for if it is for abnormal uterine bleeding, so you'll see that term AUB or abnormal uterine bleeding, then 5 years is kind of what we can kind of guarantee that it will help them with, because they've seen that at 5 years, the hormone level drops just enough that women that were having bleeding issues start to have bleeding issues again. But the hormone lasts long enough to the 8-year mark that it still protects for contraceptive purposes. I don't remember how long ago that changed, but I've seen it's gone 5, 7, and then 8. And I don't know if we've reached the end of that yet. I'm not really sure. I just had somebody yesterday that I took out her IUD. She hadn't been pregnant. She's 47, and she had it in for, she wasn't exactly sure, but it probably around 10 years. Whether or not she's still ovulating, we don't know. But so there's a chance that you guys might see another update, because it's literally from pulling cases like that where they're getting their data from. But do they have to get their IUD out at 5 years for bleeding? No. I have women that come in and see me like, oh, it's time, because whenever they got it in, they were told you need to come back in 5 years. And so like, well, I have some conversation to have with you. And I asked them, so was it put in for contraception or for bleeding or both? And if it was for bleeding, or both, then I ask if they're having any bleeding issues again. And if they say no, then a lot of them opt to just wait. And I tell them, you can just call me when you start having a little bit of bleeding or spotting, then we can change it then. Because you don't have to do it today. If you try to follow the philosophy, if it ain't broke, don't fix it. And so I have some that it's been like around the 6-year mark, they come back and see me. So they don't have to, they're still protected. And so if it's working great for them still, then I wouldn't need to push it. But I do give them the option. If they want to just get it out before they start having anything happening, then that's completely fine too, and insurance pays for it. So I think it's on my last slide. Nope, sorry. Okay. So just some things to remember. Contraindications for combined is if they have a family history of stroke, DVT, or MI, they're greater than 35 and smoking. So this is like with the OCPs, there's triphasic and monophasic and biphasic formulations. Mood swings are more common with a triphasic. Yes. Sorry, were you? Oh, okay. Mood swings are more common with the triphasic, and using the placebo week. So the more ups and downs with the hormones, you're going to have more mood swings, and that makes sense, right? So that's another benefit of skipping the placebo, is that they don't have that drop, especially so if you do the monophasic and skip the placebo, you'll have the best mood control. Okay, I think I went through all of this. So with the marina, it can be placed in office. I do have them come back in 2 to 4 weeks. So I have every week I have a like whole birth control clinic. So I do lots and lots of IUDs and Nexplanons and all that. But 2 to 4 weeks, I have them come back. We do a string check. We trim the strings if needed, because sometimes it takes a little bit of time for that string to come up and curl around the cervix so that it's not uncomfortable for them or for a partner. But sometimes if it's a little bit too long, then I do have to trim it, or I kind of use like a Texas swab and help kind of tuck it up behind the cervix a little bit. But really what you don't want to do is start out by cutting the string too short and then you can't find strings, because they're supposed to technically check for strings every month. And I have had many, many women come to me from wherever and were never told, or they think they were never told. They probably were and don't remember. Or they haven't been able to ever fill their strings because they were cut too short. But if you can't find them, then I can do a string check, look for them. If I can't find them, then we do have to do an ultrasound to see if the IUD is still there. And so it just makes it a little bit more difficult if the strings are not visible. Okay, that is it. Do you guys have any questions for me?
Are we not gonna get lab values on this shelf?
I'm trying to, sometimes they give you some and sometimes they didn't.
Okay.
I was trying to, like, as I was reading through a lot, I'm like, oh, I don't know that people would just know this. So I tried to put in whatever I could that I thought that maybe you guys wouldn't know, or, yeah.
Thank you.
You're welcome. Sure, you guys have heard the word on the street that it is hard, so don't blow it off.
It was doing 3,000 practice questions.
That's what, yeah, it's a lot. Sorry. Oh, I need to stop recording.
So much.
Yeah, thank you guys.